A decrease in the pressure of the renal artery essentially means that there is a decrease in blood pressure of the afferent arteriole. Which specialized cells that are found lining the afferent arteriole will not be sufficiently stimulated by stretch if there is a decreased pressure and therefore decreased distension of the afferent arteriole? Well, all these cells, the JG or juxtaglomerular, which means next to the glomerulus, they line both the afferent and the efferent arteriole. They are also called granular cells, so granules within them, because they are full of granules with a rather important substance that finally kicks off the discussion that we are trying to have. The JG cells, or granular cells, are full of granules that contain renin. So if our heart sucks, we have decreased blood pressure, and therefore decreased perfusion of our afferent arteriole. There's decreased stretch. The JG cells that line the afferent arteriole are not stimulated enough. They release their granules because they are granular cells, and these granules contain renin. It is important to know that the decreased stretch is not the only thing that can activate these cells to release renin. These cells also have beta 1 receptors, so that the sympathetic nervous system can also activate them and make them release renin. This is important because when we discuss how we can activate the baroreceptors in the carotid sinus and aortic arch, the resultant release of catecholamines eventually will stimulate these beta 1 receptors and cause an increase in renin release. So remember that. Baroreceptor reflex can activate renin release due to beta 1 mediated stimulation on the juxtaglomerular cells. Now, how else can hypoperfusion set off the release of renin? What is going to happen to the driving hydrostatic force in the glomerulus if we are hypoperfusing our afferent arteriole because our heart sucks? Well, that perfusion pressure is going to absolutely tank, and that driving hydrostatic force in the glomerulus is just going to drop. It'll be much slower than we want. So if the fluid is moving very slow in the lumen and at much lower pressure, the proximal tubular cells will be able to absorb a lot more sodium. So these cells are just going to take in all of this sodium because the flow is so low because we are hypoperfusing our kidney because our heart is absolutely dysfunctional. Or it's functional and it's not compliant enough and can't fill with enough blood to send forward. So eventually what happens is that these proximal convoluted tubular cells will take out all of the sodium. It'll travel to the distal convoluted tubule, where we have our diagram also illustrating this in the distal tubule, where the macula densa cells will sample the fluid or urine, which will be inside this component that we are forming. So we're forming urine that we pulled a bunch of sodium out of because we were being hypoperfused in our kidneys. So the macula densa cells will be deprived of sodium because we've absorbed as much as we could in those proximal tubular cells, because the flow through that glomerulus is so slow, and we're not filtrating with enough hydrostatic pressure. When these macula densa cells realize there's not enough sodium, they don't like that at all. They will start producing cyclooxygenase 2 because it wants to make prostaglandin E2 and prostaglandin I2, which is prostacyclin. What do these do for us? These are both potent vascular smooth muscle dilators. The net effect is to have a vasodilatation of this afferent arteriole because we feel like it's not getting enough blood, so let's open up that vessel and get more blood in there. This will help increase the amount of blood entering the afferent arteriole, which in step 1 terms should be thought of as an increased renal plasma flow. Do you remember the equation? Renal blood flow equals renal plasma flow divided by 1 minus the hematocrit. We need to increase afferent arterial dilation to get more renal blood flow because the kidney has detected that our systolic or diastolic dysfunction has not allowed enough forward perfusion. So our heart is messing us up real bad here. It's setting off these neurohormonal reactions in the kidney. A good way to remember this is that you inhibit cyclooxygenase with a non-steroidal anti-inflammatory drug, and you never want to give someone an NSAID that has kidney problems because you'll inhibit this whole process. and then they can't dilate their afferent arteriole, you'll cause vasoconstriction of the afferent arteriole, and you'll have even more decreased perfusion to the glomerular capillaries. So that is why you never give NSAIDs to anyone with problems with their kidneys or problems adequately perfusing their kidneys. Another key element to understand is that we will also have angiotensin II around because we activated the renin-angiotensin-aldosterone system when we stimulated these JG cells to release renin. Remember, renin will activate angiotensinogen to be released. That will eventually cause us to have angiotensinogen 1. That will eventually cause us to have angiotensin 1. And then we will have angiotensin 2. Angiotensin 2 binds to receptors on the efferent arteriole, causing vasoconstriction. And it also binds to systemic vessels, causing vasoconstriction. This will further increase the renal plasma flow and increase the GFR. Just think about it. We open this to get more flow, and then we made this narrow. Blood is going to go in here preferentially instead of just flow here and then come back out. We give it more time because we've decreased the diameter of this efferent arteriole so that blood will spend much more time in here at a higher pressure. Now, what else do we need to know? We need to know the summary. We need to get back to what we're talking about. This is incredibly important to know, but I'm sure you guys want to hear more about cardiology. So let's summarize. There are 3 ways that we can activate renin release from the JG cells. Number 1, we can bind beta-1 receptors directly on the cells. Number 2, a decrease in blood pressure or hypoperfusion causes a decrease in stretch of the JG cells, which means that they release renin. Number 3, hypoperfusion means that we will have more time and less flow, allowing these proximal tubule cells to absorb all the sodium out of the intraglomerular fluid, which is going to be our urine. So decreased sodium delivery to the macula densa. Excellent. Now, back to this diagram. So, we just discussed a lot of this diagram. We have the kidney in all of those different ways, the 3 ways we just mentioned, causing renin release. This leads to production of angiotensin II, and then we get vascular smooth muscle cell contraction, which leads to vasoconstriction, increasing our TPR, and this also leads to growth promoting factors, including stimulation of fibroblasts, which is how you get some of the remodeling of the heart. So the renin released cleaves angiotensinogen into angiotensin 1. Angiotensin 1 is cleaved by endothelial-bound angiotensin converting enzyme in the pulmonary vasculature, and now we have angiotensin 2. So let's work from right to left here on the diagram. So angiotensin 2 will induce aldosterone synthase. It will stimulate the cells of the zona glomerulosa, so it will increase the production and release of aldosterone, as well as stimulating the adrenal medulla to increase the production of catecholamines. And these catecholamines will go on to stimulate beta-1 receptors in the heart, and then further stimulate beta-1 receptors on the JG cells that are releasing all this renin. What are the names of the cells in the adrenal medulla that synthesize norepinephrine and epinephrine? These are our chromaffin cells. Let's take one step further here and include some biochemistry review, because this is how test question writers will come at you. You'll be reading a question about the renin-angiotensin-aldosterone system, and all of a sudden they'll throw a curveball and ask you about the stimulation of the adrenal gland by angiotensin 2, and then they'll ask you what cells, or about one of the steps in the synthesis of the chromaffin cells producing norepinephrine and epinephrine. So let's discuss that real quickly. In the chromaffin cells of the adrenal medulla, tyrosine hydroxylase will take tyrosine and make dopa. Amino acid decarboxylase will take dopa and make dopamine. Dopamine beta hydroxylase will take dopamine and convert it into norepinephrine. And a very long phenyl, ethanol, amine, N-methyl transferase will do exactly just what it says. It will transfer a methyl group from norepinephrine to an epinephrine and make epinephrine. You better know these enzymes' names. Test examiners will write them completely all the way out on your Step 1 exam, and these could potentially be the 4 answer choices you see on a question. So now let's return to our figure. We know that angiotensin II causes vasoconstriction of the efferent arteriole, and it also stimulates the sodium proton antiporter of the proximal tubular cells to increase sodium uptake, and that is listed here, and that leads to increased water retention. Systemically, it can also cause vasoconstriction of the peripheral resistance arterioles, while also causing the release of growth factors that can cause angiogenesis, and also stimulate fibroblasts, which causes ventricular remodeling. We've said this, but repetition is key. It is the only way you're going to remember this stuff. It's impossible to retain it all the first time through. The constriction of the total peripheral resistance arterioles causes an increase in diastolic blood pressure, while also increasing the afterload. You should kind of make these similar in your mind, but there are other reasons that you can increase afterload, such as aortic stenosis. The main mechanism by which the renin-angiotensin-aldosterone system will increase intravascular volume is what? It is the induction of an enzyme by angiotensin II that we just said, aldosterone synthase. You must know the following about aldosterone basically forever. A large percent of your patients will be on some sort of drug that inhibits the RAS system, so you have to know it forwards and backwards. Let's discuss what aldosterone does. Number 1, it induces the transcription. Remember, it is a steroid hormone, so many of its effects are due to the increased transcription and production of ion channels in the principal cells in the renal tubules. So number 1, it increases ENaC and ROM-K. ENaC is a channel on the membrane that increases sodium reuptake, and ROM-K is a channel on the membrane that increases potassium dumping. This is the lumen of our tubule, and this is the lumen of our tubule. What else will it do? Number 2, it will increase basolateral sodium potassium ATP ACE pumps. This should make a lot of sense to you. Aldosterone is a potassium wasting hormone. If this is our lumen and we have more ROM-K channels and sodium channels on the membrane, we'll be taking up sodium, dumping potassium, and then if we put more sodium potassium ATPase pumps on the basolateral side of these cells, we'll now be driving that sodium into the interstitial environment while pushing more potassium into the cell, and then that will just leak out into the lumen of our tubules, and then it will be excreted in the urine. Alright guys, sorry about all that, but you have to understand how intricate and how complex these systems are to understand what question I'm going to ask you about atrial natriuretic peptide. You have to know what it can block and understand what it can block before you can answer the question about it. So finally, let's get to the atrial natriuretic peptide diagram we have on here. So atrial natriuretic peptide stimulates guanylyl cyclase, and we know very well that this will increase cyclic GMP, which activates a cyclic GMP dependent protein kinase, the old famous protein kinase G. Now protein kinase G will phosphorylate things. Guess what it likes to phosphorylate? Do you remember the name of that sodium channel that aldosterone just inserted into the apical surface? Well, aldosterone just put that sodium channel ENaC, and ANP is going to lead to a signaling cascade that's going to phosphorylate that ENaC, and this means that you will get a decreased influx of sodium into those cells from the lumen because you put a phosphate group on it and you cause a conformational change and you block that sodium channel. Therefore, you will natriurease or pee out sodium in the urine. ANP also binds to the afferent and efferent arterioles, causing massive vasodilatation. So it causes vasodilatation, and anytime you vasodilate that afferent arteriole, you're going to increase hydrostatic pressure in the glomerulus and raise the glomerular filtration rate. This will also cause increased delivery of sodium to the macula densa cells. Increased delivery to the macula densa cells will not stimulate those cells to set off that cascade of renin release. So we also decrease renin. Therefore, we have a total of decreased renin release, increasing our GFR, vasodilating the afferent and efferent arterioles, causing a decrease in blood pressure, because it is also a systemic-wide vasodilatation, and secondarily, this decrease of renin production will lead to a decrease in angiotensin II, and a decrease in angiotensin II will lead to a decrease in the production of aldosterone. Therefore, we have another component, which is a decrease of the aldosterone that is circulating around, hence the term the aldosterone escape mechanism. So, in summary, it basically counteracts the effects of activating the renin-angiotensin-aldosterone system in many different ways. Now, B-type, or brain-type natriuretic peptide, is another important peptide you must know about. Do not let the name fool you into thinking it has anything to do with the brain. It was just named that because it was originally discovered in a research lab using pig brains. In humans, you need to think BNP equals VNP, which is basically because it is released by ventricular myocytes under stress. So again, ventricular wall tension will create stress, and it will cause the ventricular myocytes to release B-type natriuretic peptide. Normally, your ventricular myocytes should not be making BNP at all. It's only under stress that they should be making it and releasing it. So this is a very helpful lab value to measure the progression of heart failure. It is only increased when there's an increased tension of the ventricular wall, which is basically caused by excessive stretching of the sarcomeres that compose that ventricular myocardium. It has the exact same mechanism of actions of ANP, except that it has a much longer half-life and is only released during excessive tension due to ventricular wall stress. Do not forget this. That is why you can use it as a heart failure marker to see how the patient is progressing. There's actually a drug called natriuretic that is a synthetic homologue of BNP, and that is very beneficial because you can get all of the beneficial results of ANP, which are the exact same as BNP, by giving this to your patient. So we discussed a bunch of things in this section. You guys did a great job of staying along. Remember how we discussed some baroreceptors in the juxtaglomerular apparatus while we were reviewing the RAS system in order to understand what ANP and BNP do.